hypercoagulable states, and also DVT. Okay, so this one is clear cut lah, okay, that will affect the coagulation. And then the hypercoagulable states, as you know, we have it's a multifactorial, okay. So you can have other diseases, for example, antiphospholipid syndromes, okay, that promotes the hypercoagulability, okay. Any other syndromes that you can think of? Okay, so along the, do you remember the coagulation cascade? Right, okay, so anything that has deficiencies, okay, in certain factors can cause a hypercoagulability state, right? Okay, for example, you have protein C deficiencies, okay, that's promote the hypercoagulability, okay, and what else? What else? Okay, pathophysiology. If you have any other cardiovascular diseases, okay, or diseases, malignancy, okay, can increase the coagulation. If you are smoking, okay, if you have a hypertension, so these are the factors that contribute to the hypercoagulability states. And don't forget the inflammation, okay, and the inflammation caused by, other than smoking, inflammation is caused by infection, okay. So the easiest, the one that is close to what happened at the moment is the COVID-19, where you have cytokines storm, okay, which shows inflammation, okay, then you have the hypercoagulable state, okay. Right, these are the prerequisite knowledge. Okay, go back and look at the coagulation cascade and how the fibrinolysis process, okay, and thrombosis. Right, can refer the LO in your study guide as well. Okay, so just to recap these terms, okay, hemostasis is the clotting of blood to prevent exsanguination from accidental or surgical injury to a blood vessel. Okay, it is always a localized process, okay, where you have injury, okay, endothelial injury or exposure of the endothelial on your blood vessels, no? Okay, so the hemostasis should come, okay, right, and it should be in localized process. What happen if it's a systemic? So semua your body is either tak boleh clot ataupun clot, okay, so that is less likely to happen lah, okay. And this hemostasis produce a hemostatic clot which do not form in the circulating blood, okay. What is the difference between thrombus and thrombosis? Thrombus is a blood clot, okay, and thrombosis is the process, okay, by which circulating blood is stopped by a thrombus. Do you think you are familiar with this DIC? Okay, you have learned in pathology, okay, and then when we talk about thrombosis, it can happen either in your artery or in the venous, okay. And I hope that you are aware the different composition and the cause, okay, of the arterial thrombosis and the venous thrombosis. Okay. So what are the mechanisms? Why do we need to know all this? Because it's very related with the treatment, okay. So when we design the treatment, as usual, we need to identify the mechanism. What are the pathological mechanisms that leads to the condition? And we try to develop a pharmacological targets that can use a certain mechanism, that can halt a certain mechanism, okay? So the first one is the initiating of clotting by tissue factors, okay, and factor 7. Prothrombin conversion to thrombin on phospholipid surfaces, platelet activation, okay, fibrinopeptide release from fibrinogen by thrombin, polymerization of fibrin monomer, cross-linking of fibrin by activated factor 13, entrapment of blood cells within the fibrin network. So these are all the process that involve in the hemostasis, okay, to form a clot. Okay. So how do we diagnose if there's a thrombosis? Okay, you look at the clinical signs and symptoms, as you all aware, and we can also use radiographic, ultrasound, and also MRI. There are also laboratory testing that we can use to diagnose the underlying cause for thrombosis. Okay, for example, huh? for example, okay, kalau kita nak monitor coagulation, the normal ke tidak, apa yang test yang guna? We have the APTT, proton time. We can also evaluate the D-dimers, okay, and others lah kalau ada. And of course, you can use molecular markers as well. Okay. However, for molecular markers, we don't use it in diagnosis because of the cost and also it's time consuming. Yeah. Okay. So basically, we use the molecular markers to in some research. Okay. Right. Acute coronary syndrome (ACS). Okay. This include the unstable angina and myocardial infarction. Okay, which constitute the most common cause of cardiovascular death. The cause of ACS is the erosion or rupture of an atherosclerotic plaque with subsequent platelet adherence, activation, aggregation, and activation of the clotting cascade. Okay, so this is where we have to target. Okay, so we have the antiplatelet for this. Since for this thrombus, okay, when you have the plaque rupture, okay, so kita tak nak dia apa tu terjadi lagi lah. So we have to give some prevention, some prophylaxis. Okay, so which target that we should use? We can target the platelets. Okay, so platelets is the culprit for the arterial thrombosis. Okay. And it starts when you have the endothelial dysfunction. Okay, so apa itu endothelial dysfunction? Okay, just imagine you have, let's say, a normal blood vessel. You have a very intact and organized endothelial lining. Okay, which has a function to regulate the coagulation, the clotting. Okay, because endothelium will have nitric oxide and also prostacyclin. So this will keep check and balance lah. So kalau ada semacam we need to control the coagulation. The endothelial cells supposed to produce nitric oxide and also prostacyclin to inhibit the coagulation, inhibits the platelet. Okay, specifically. Okay, so when you have endothelial dysfunction, means that the endothelials are not well. They cannot produce nitric oxide or prostacyclin. They are exposing the collagen. They are exposing the von Willebrand factors on the surface of the site of injury, and that is where the platelet counts and the thrombosis will start to happen. Okay, and these are the factors that contributes to the atherosclerosis that I think you are all aware of this. Okay. So generally, the pharmacotherapy includes the combinations of the anticoagulants, okay, the traditional ones, and also fibrinolytics and antiplatelets, okay. And most of the time, we found out that we can or we should combine to be the more traditional therapies such as nitrates and beta-adrenergic blockers. Okay. So other than that, we can do, I think we have heard this before, PCR percutaneous coronary intervention and also bypass graft surgery, okay, if you have the clot. Okay. So just go briefly, there's a characteristic of this clot, okay, right? Yang mana yang clot yang senang rupture. So I think yang ni yang you dah belajar lah, okay. So the plaques that are more susceptible to rupture encompass less than 50% of the coronary lumen, okay. Eccentric shape, thin fibrous cap, Okay, a large fatty core, high content in inflammatory cells, okay, limited amount of smooth muscle cells, significant compensatory enlargement, okay, and when it's ruptured, okay, there will be a formation of occlusive or completely occlusive thrombus, which is a clot that forms on top of the ruptured plug. Okay, so this ruptured plug is disebabkan apa? When you have the factors lah, you ada apa? Hyperlipidemic lah, diabetes lah, or excessive exercise, bukan, okay, smoking, okay, and then bila dia dah ruptured tu, okay, that's leave the surface, the endothelial site of the injury to exposed. That triggers the formation of thrombosis. Okay, the thrombus, okay, will occur. Okay, so what happens when you have the site of injury? So this is your blood vessel. Okay, there will be a reflex vessel constriction here, as you know. Okay, when you have a vessel constriction, okay, so it means that the shear stress or the pressure will increase, right? And this shear stress will activate the platelets. So what else can activate the platelet? This is the initiation of the thrombosis, okay? Alright. So this vessel constriction factors are caused by the endothelin release by the endothelial cells, and when you have the injury, of course, in the extracellular matrix, you have the collagen, okay, and this collagen exposed can also interact with the platelets. Where's the platelets here? Okay, so the yellow color is the platelets. Okay, so you need to understand this, because when we talk about antiplatelet, we have a various class of antiplatelets that targets this different platelets pathway. Okay, so what happens next is that when they detect that there is a site of injury on your endothelial, on the blood vessels, okay, so the first platelets will come, and how do they recognize it? Okay, because you have exposure of collagen, okay, and they also can detect the von Willebrand factors, right? So von Willebrand factors are expressed on the endothelial cells, and on your platelets there's receptors that can recognize this collagen and von Willebrand factors. Okay, so they come. So what they do? They come here to the site of injury and adhere. So that is the first events that occur. The adhere seolah-olah dia beratur susun adhere, what is melekat, something like that. Okay, to cover the site of injury. Okay, and then they will undergo a transition shape change. Okay, kenapa shape change ni? Is because platelets is a very special cells. They don't have nucleus, right? Okay, but they have abundance of receptors and granules. So when they are activated, they will have a certain changes. Okay, the shape change means that from around platelets, okay, dia akan form jejari. Okay, and then this jejari ni, okay, is part of the punya signaling mechanism, because they are trying to reach the other cells and come, okay, to the site of injury, and they also release ADP and thromboxane, which can further activate the other platelets, okay, and recruits the other platelets to come to that site, okay. Right, and that is what we call recruitment. And then once it forms a plug, okay, we call it aggregation or hemostatic plug. Okay, aggregation means they all forms a clump of clot together. Okay, right, and lastly, okay, this will occur. Okay, the tissue factors, phospholipid complex expression will stabilize the platelet. Okay, and then you have a thrombin activation to stabilize. Okay, and lastly is the fibrin polymerization. So fibrin polymerization will form a fibrin mesh on top of your hemostatic plug to keep it stable. Okay. Right. If you remember this or have, I'm not sure if you have go through this platelets activation. Okay, but you can find this in Katzone. Okay, so these are the process of platelets activation. It shows you this is GP2B3A is the receptors. Okay, where we have a drug that's targeting the GP2B3A activation. Okay. And you can see here prostacyclin is from the endothelial cells can inhibit the activations of the platelets. Okay, this is part of the regulation. Okay, and this is where the coagulation cascade intersect with the platelets activation pathways. Okay, so don't get confused. Kadang you macam mana ni you have platelets and you have a coagulation, kat mana dia apa tu dia ada intersects tu. Okay, so this is the where it intersect, where you have the full coagulation cascades that end up with the formation of a thrombin. Okay, and the thrombin, okay, will activate the platelets further and also activates the conversion of fibrinogen to fibrin. Okay. Okay. Right. So I think you are familiar with the coagulation cascade. Okay. At the end, you want this to be to produce by the coagulation cascade thrombin. Okay. Right. So let's go to the drugs we have as that we can use as anticoagulants as well as fibrinolytic agents. Okay. So for the drugs, why is it that we call this anticoagulant? We don't call this anticoagulants, but anticoagulant is the subgroup. Okay, so all of this is the drugs that can affect the thrombus formation or drugs that can affect the thrombosis. Okay, so we have 4 different groups. Okay, the first one is anticoagulant. Okay, and then fibrinolytics. Okay. And we also have antiplatelets, okay, and antifibrinolytics. Okay, so you must be wondering why this one is in the red circle. Okay, so the blue circles, these three groups, inhibits or can disrupt the formation of thrombus. Okay, right. Except for the antifibrinolytics. Antifibrinolytic is when we want the thrombus to stabilize, the clot to be stabilized. Okay, but still, all of these 4 groups are the drugs that can affect the thrombus formation. Okay, so we look at the first group. So these are some of the drugs, okay, that you have to remember. They have a different mechanism, of course, for each, okay, and even in antiplatelets group, okay, each of these examples has a different mechanism of actions, okay. Right, let's have a look at the anticoagulants. We have heparin and also warfarin, okay. Right, so for the warfarin, okay, it is given as an oral. Okay, so warfarin is given as oral. Both types of heparin is by parenteral. Okay, it's either intravenous ataupun subcutaneous. Okay, now we look at the anticoagulant first. Okay, so when we say injectable anticoagulant, you know already it should be heparin. Okay, so heparin, there's 2 types. Okay, the normal heparin we call unfractionated heparin, UHH ataupun HMWH is the high molecular weight heparin, okay, and then the other type is a low molecular weight heparin, okay, LMWH. Okay, so what is heparin? Heparin is a mixture of sulfated mucopolysaccharides which occurs mostly in the granules of mast cells, and it can be destroyed by macrophage. Normally, heparin is undetected in plasma. Okay, so dia ada circulate in a very small amount that you cannot detect in the plasma, tapi dia ada. Okay, so kalau dia the concentration, plasma concentration is high for heparin, so habislah kita punya blood tu tak boleh clot kalau ada injury. Okay, mechanism of action. acts as a cofactor of antithrombin 3 and enhance its deactivation of factor 10A. Okay, so what is the function of antithrombin 3? Okay, kau tengok dekat in this diagram, this one you can refer to cartoon. Okay, so you have this antithrombin 3. Okay, right, this is antithrombin 3. Okay, so the function of antithrombin 3 is to deactivate thrombin. Okay, so kalau you ada antithrombin 3, thrombin you takkan function, then you takkan dapat blood clot. Okay, alright, so keep that in mind. That is the function of antithrombin 3. Okay, and apa dia buat ialah untuk thrombin ni, okay, kalau you tengok the coagulation cascade tu, thrombin is when they want to have a functional thrombin, okay, they must have a factor 10A lah. Okay, so antithrombin 3 will interact or inhibits this complex, so you will not have a functional thrombin. Now when you have heparin, okay, so this is example, this is a very good diagram to show you. Okay, let's say you have a heparin, this yang brown ni, okay, right, the brown ni is the normal heparin, the UFH heparin, okay, the unfractionated one. And when you kata unfractionated or high molecular weight, of course dia long chain, okay, dia panjang, so dia akan binds with the antithrombin 3 and help the antithrombin 3 to inhibit the thrombin formation. Okay, so because dia panjang ni, okay, so dia akan binds to this sampailah ke thrombin complex. Okay, right, so what about the low molecular weight heparin? Okay, because it's shorter, it cannot bind to the thrombin, but the inhibition of the thrombin is enough and you can bind to the factor 10A. Sebab factor 10A tak ada thrombin. Okay, you tak boleh nak convert prothrombin to thrombin pun. Okay, so most important is the factor 10A. Okay, right. Okay, antithrombin 3 with the heparin increases degradation of both factor 10A and thrombin. Okay, so this example of unfractionated heparin yang we commonly used in our country. Okay, so we have a Unihepa under Duo Pharma and also Taxol heparin sodium marketed by Contra Pharma. Okay, for low molecular weight heparin, okay, we have enoxaparin ataupun kita panggil Clexane lah, tapi there are few other brands. Okay, right, these are one of the famous brand, Clexane by Aventis. Okay, and we also have a fondaparinux known as Elixtra, marketed by GSK. Okay, both are ready in a prepared pre-injectable syringe. Okay, so you just bagi injection je lah. Kalau bonus lah, IV ataupun subcutaneous. Okay, tapi dia dah siap dengan syringe. Okay. Heparin increase the rate of catalytic reaction of thrombin, antithrombins in about 1,000 folds. Okay, so after the binding of thrombin and antithrombin, heparin is released and can act again to bind with another antithrombin. Okay, if you increase the dose of heparin, okay, the most of the people showed that it can also inhibit platelets aggregation. Okay, low molecular weight heparin have equal efficacy with unfractionated heparin. Okay, and increased bioavailability from subcutaneous injection and lesser dosing requirements. So these are the advantages of giving low molecular weight heparin as compared to UFH, but both have the same efficacy. Okay, because as long as you can bind to the factor 10A, okay, you will not have a thrombin. Okay, it will be degraded. Okay, but if you give both as a subcutaneous injection, you can compare that the bioavailability of the low molecular weight heparin is much better, and it's only require a lesser dosing requirement. Okay? Clinical uses of heparin as a prophylaxis of reocclusion of the coronary artery following thrombolytic therapy in myocardial infarction, peripheral arterial embolism, unstable angina and venous thromboembolism, and also prophylaxis of post-operative venous thromboembolism. Okay. Pharmacokinetics. We don't have any option. We can only inject heparin, okay? Because of course it will not be absorbed through the GIT mucosa. So you can choose either you want to give continuous intravenous infusion, intermittent IV, and also deep subcutaneous injection. Okay, it depends on the case as well. Okay, right. For the IV, as you know, onset of action is immediate. Okay, but for the subcutaneous, the onset of action is delayed by 1 to 2 hours. Plasma half-life depends on the dose and shortened in patients with PE and prolonged in patients with a hepatic cirrhosis and advanced renal insufficiency. Okay, standard administration is by bolus injection followed by a maintenance dose delivered by an infusion pump. Okay, so if you give heparin, you need to monitor their APTT. Okay, so once the stable APTT value is obtained, lab monitoring is not necessary. Okay, that's why kalau heparin biasanya adalah di hospital sahaja. Sebab kita nak monitor APTT patient. Bila kita discharge, maknanya dia dah pass the heparin treatment, so they can continue the treatment tu with the oral anticoagulant, which is warfarin. Okay, ataupun we can start with the other drugs, for example antiplatelets. Okay, adverse effects. Yes, the first problem, this is very important, is bleeding. Okay, so you see the range is quite big, 1 to 33% of patients. Okay, and so you need to carefully select your patient. Okay, make sure that before you start the heparin tu, kalau if it's not in the case of emergency, kan, you kena tengok lah the patient's profile. Okay, and control of the dosage and to monitor their APTT throughout the treatment. Okay, heparin-induced thrombocytopenia can occur. Okay, what is thrombocytopenia? When you have a low platelet count, right? Kenapa pula kita bagi heparin, lepas tu platelets tu turun, okay, decrease platelets. So this condition occur in 25% of patients due to heparin-induced platelets aggregation. So the platelets is being used, okay, in the process of aggregation, kan, maknanya dia form a clot. Okay, that's why bila you do the platelet count, nanti you ambil blood sikit tu, you tengoklah dia punya blood profile, tengok kenapa pula platelet count dia tu rendah. Punya dia ambil heparin, okay, kita bagi dia heparin, so it could be the heparin induced aggregation. So kena tengok balik lah the dose dan tengok balik the APTT. Okay, 5% of patients develop severe thrombocytopenia caused by heparin-induced antiplatelet antibodies. Okay, hypersensitivity reactions can occur. Okay, chills, fever, urticaria, asthma, and rhinitis, alopecia. And if you give heparin as a prolonged therapy, there's a risk of osteoporosis. Contraindication, thrombocytopenia, bleeding disorder, active peptide ulcer disease, severe hypertension. Okay, so if there's a life-threatening bleeding due to heparin, okay, kita ada antidote. You can give a protamine sulfate. Okay, so this protamine sulfates will inactivate the heparin and reverse the heparin's effect. Okay. Right, so is there any issue? That is a bit nakui lah sikit kalau you tahu dulu ada history lah yang orang tak nak terima, tak nak ambil ni heparin injection, since they know that okay, this is not been, kalau you tengok mana-mana insert for the taxane, okay, dia tak ada mention the source of taxane. Okay, tapi the taxane ialah the heparin that is extracted from the intestinal mucosa of a porcine. Okay, bila ada issue, they don't declare, they don't even put it in the insert dalam box tu. Okay, and there are also few other brands yang kita memang daripada in the final proposal tu, tapi dia tak mention di dalam insert tu. Dan itu sebenarnya hukumnya adalah haram pada masa sekarang. Dulu dikira darurat sebelum adanya fatwa disebabkan kita tidak ada alternatif. Okay, anticoagulant. And you know that anticoagulant is used when patient tu dah ada MI kan. It's a very dangerous situation. Okay, so kita agak terdesak, so we can use the taxane. But now we have the alternative. Now we have for the Fibrinolytic, okay, which they use molecular or recombinant technology, okay, or extra. I think the price now is getting better as compared to when they start release this extra. So most of the setting, I mean in the hospital kita masih lagi ada taxane, tapi mostly we use extra. Okay, right. So we have okay, we have covered the anticoagulants, the heparin. Okay, the other one is a direct thrombin inhibitors, which I tak mention di dalam jadual tadi tu, dalam table tadi tu. Okay, right. But this is also anticoagulant. Okay, direct thrombin inhibitors means that this agent directly targets the thrombin. Kalau heparin, it must bind to the factor 10A. Okay, and plus minus binds to the thrombin. Okay, but for the direct thrombin inhibitors, it means that these drugs directly binds to the active sites of the thrombin and thus inhibiting the thrombin's downstream effects. That means there will be no fibrins and also platelets activation. So gambarnya agak blur. Sorry saya sebenarnya tak apa sihat, batuk-batuk. Okay, so right, you can see from here is okay. So you have this okay, this is your thrombin. Okay, yang ni kalau if you want to have a different diagram lah, okay, to understand the thrombin production or generation. Okay, so these are from the coagulation cascade, and finally you have the thrombin. And then what inhibits the thrombin is the antithrombin, and this is where your heparin acts. Okay, and this thrombin, as part of the regulation, okay, the thrombin also activates the thrombomodulin to produce protein C and protein S complex. So these are the coagulation inhibitors. Okay, now what this DTI do? Okay, right, if you look at this, this is thrombin, this one is heparin, this is the antithrombin. Okay, and on the thrombin there is a active site of thrombin, and this is exosite 1 and exosite 2. Okay, so just imagine that there are dua different tapak. Okay, exosite 1 and 2, and also the active site, okay, on the thrombin. So for the antithrombin, okay, to work, dia akan bind to the active site ni lah. So you tengok dia punya moncong ni boleh masuk kat sini. Okay, right. And then kalau you ada heparin, okay, when you give heparin, okay, together with the antithrombin, it will increase the catalytic reaction up to 1000 folds, just like I told you before. Okay, right. So what happen if you have a DTI? Okay, DTI, okay, so dia ada dua. DTI means that dia tak perlu binds kepada factor 10A. So they binds directly to the to the thrombin. So for the DTI ni, if it is a univalent DTI, okay, maknanya univalent ni dia ada satu site saja yang dia binds pada thrombin. Okay, so dia akan park kat sini, right? And this is how it works. Bila dia park dekat sini, your thrombin will not work. Okay, and the other type of DTI is what we call bivalent. Okay, So tengok bentuk dia pun macam ada dua side kat sini So bivalent. So dia akan go to the thrombin and binds to the two sides of thrombin. Okay, so side 1 and the active side. Okay, boleh nampak kita tak ada video kat sini, tapi this is a very good pictures to describe what happened between DTI and thrombin. Okay. Okay, so example of DTI, okay, we have hirudin and hirudin derivatives and bivalirudin. Okay, for example, hirudin derivatives are lepirudin and desirudin. Okay, these are the bivalent DTI, means that they bind to two sides of thrombin. Okay, and then we have alga-thrombin and megalatran. Okay, this is univalent DTI. Okay. Dan in Malaysia pun memang kita pakai lah univalent ni. Okay, we use Pradaxa or dabigatran. Okay, produced by Boehringer Ingelheim. Okay. Pharmacokinetics of DTI, okay, is given as injection. Okay, sebab tu saya letak this DTI ni di bawah heparin, sebab heparin is parenteral, DTI is also parenteral. Okay, kebanyakannya. Okay, kebanyakannya kita bagi DTI as parenteral kecuali dabigatran. Okay, so you can be given as a intravenous and subcutaneous, sama seperti heparin, right? Okay, so we finish with the oral or injectable anticoagulant. Now we start with the warfarin. Okay, warfarin is a vitamin K antagonist. Okay, ini adalah ubat makan. Kalau cakap dekat makcik-makcik tu kan, okay, ubat makan untuk cair darah. Okay, baru dia faham. But this is anticoagulant, oral anticoagulant. Okay. And then what is the mechanism of action? Okay, it inhibits vitamin K reductase, which reduce vitamin K to active hydroquinone, and important for the normal synthesis of coagulation factors 2, 7, 9, and 10, as well as anticoagulant protein C and S. Okay, so this is the function of vitamin K. So in order for us to produce all these factors in a coagulation cascade, okay, we need to have a vitamin K, okay, daripada reduced form to the epoxide form, okay, and we need to have a function vitamin K epoxide reductase. So this is where the warfarin hijack this pathway, okay. So you will not have any factors produced for the coagulation cascade. Okay. So onset of action, because the effects banyak factors, maknanya banyak factors coagulation itu bergantung kepada vitamin K. So the onset of action depends on the half-life of the clotting factors. Okay. So this is natural. Clotting factors kita tu mempunyai half-life yang berbeza. Okay, so it depends on each of the clotting factors. Okay, pharmacokinetics, complete absorption following oral administration. Okay, plasma detection in about 1 hour. Peak plasma concentration after 2 to 8 hours. Okay, high plasma binding protein. Okay, plasma half-life about 25 to 60 hours. Duration of action 2 to 5 days. But this drug can cross placenta. So if you have a case of pregnant mothers, okay, with the hypercoagulable state, DVT for example, we don't give a warfarin. Okay, heparin is quite safe for the pregnant mothers. So it means that she has to be admitted to the ward. Dan kita monitor sampai dah dia bersalin. Okay. Effect is monitored by measuring prothrombin time. Okay. So I think you know what is the PT, how do we measure the PT, and we also have to check the INR. Okay. Adverse effects, bleeding. If major bleeding occurs, vitamin K1 is an effective antidote. Okay. So kalau heparin overdose, you ada bleeding, you give protamine sulfate. Kalau warfarin, you bagi vitamin K. Okay. Fetal malformations or abortion results from the administration to vitamin. Okay. Right, so these are the drug interactions, okay? Drugs or conditions that are potentially dangerous in patients taking warfarin, thus increasing the risk of hemorrhage. Okay, so this one you boleh baca lah, drugs that um, alter the uptake metabolism of warfarin or vitamin K, drugs that affects the synthesis function of various protein factors, okay, drugs that affects the integrity of epithelia and the other diseases, for example, liver disease, okay, fever and thyrotoxicosis, okay. This increase the metabolic rate, thus increase the degradation of the protein factors, okay. Right. Drugs that potentiate oral anticoagulants, drugs that inhibit hepatic metabolism, okay, therefore you have increased effects of warfarin, for example, cimetidine and omeprazole. Drugs that inhibit platelet function, okay, kalau you bagi warfarin, at the same time dia pun ambil juga antiplatelet, means that the dah double dah, you can inhibit the coagulation, kan, okay. So this may cause the bleeding, okay. Drugs that inhibit reduction of vitamin K, for example, the cephalosporin antibiotics. Drugs that decreases bioavailability of vitamin K, for example, broad-spectrum antibiotics, and drugs that displace warfarin from the binding sites of the plasma albumin. Okay. Okay, and these are the conditions that decrease the effects of oral anticoagulant of warfarin: pregnancy, hypothyroidism, okay, vitamin K, okay, that's why we can use it as an antidote. Carbamazepine, rifampicin, and barbiturates, okay, these are enzyme inducers, and then cholestyramine. Okay, so we finish with the anticoagulants. Okay, saya mungkin akan terpaksa ambil masa you sikit lah. Tapi sebab ni apa, saya study apalah, break dan puasa lah, tak payah break lah. Okay, what aspects of platelet function contribute to thrombotic events? I think you dah tahu lah macam mana platelets works, okay? But these are the sequence of events of the platelets role in the thrombosis. Okay, like I mentioned just now, you have the addition, aggregation, thromboxane synthesis, granule secretion, and then the platelets also can bind to your leukocyte, okay, that forms the conjugation complex. Okay, microparticle formation, okay, like I said, these cells doesn't have nucleus, so apart from, they have an abundance of receptors in granules, okay, they can also what you call the budding, they call budding formation from the cells, okay, and then they circulate in your blood as a microparticle, MMP, okay, and this microparticle is active. It can also interact with the other parts of your body and also can trigger the coagulation, okay, and then lastly we have a thrombin and fibrin generation. Right, I think I'll just go through this quickly. Okay, so when we said that we want to use the platelets as our target, okay, to inhibit the coagulation, okay, so you can either, okay, inhibit the anything in the cells, the granules, or you can target the receptors. As I mentioned to you, the platelets express many types of receptors, okay, berpuluh-puluh thousand copies, okay, so supaya dia lebih sensitif bila ada signal. GP2P3A for example, I can't remember berapa puluh thousand copies, tapi dia yang paling banyak lah, is the most abundant receptors, and is very very sensitive, okay, to vulnerable factors, right? So we can use these receptors to target the antiplatelets or inhibit the antiplatelet, okay? So when we study the platelets, these are the things, okay, naturally we have a phosphocyclin and nitric oxides, okay, and then we have ADP removal by CD39, because ADP can also trigger the platelet activation, adenosine, and also now we are looking into this prostaglandin, right? As prostaglandin is being produced when you have inflammation, so I think this is a good area to study lending involvement in modulating the platelets. Okay, so what are the current approach to modulate platelet function pharmacologically? So these are the groups that we have. Okay, these are the antiplatelets. We have aspirin. Aspirin can inhibit the cyclooxygenase. Okay, ni dah belajar kan in NSAIDs? Alright, right. So aspirin will inhibit the cyclooxygenase 1 and 2 because it's NSAID. Okay, kalau COX-6 we only inhibit COX-2. Alright. So which COX is being expressed in the platelets? So the platelets have COX-1. COX-1, remember COX-1 is a housekeeping cyclooxygenase. Maknanya dia akan sentiasa berada dan function. As compared to the COX-2, bila you ada inflammation, barulah COX-2 akan bekerja. Alright. Right, so bila you inhibit the cyclooxygenase 1 in the platelets, you will not have thromboxane. This thromboxane is important to activate the platelets. Okay, so we can use aspirin. Number 2, we have a thienopyridines drug groups which inhibits the ADP receptors. Okay, for example, clopidogrel. Okay, this one saya akan we can go through in detail. Okay, but this is just to show you the groups that we have as antiplatelet. And then we have a GP2B3A antagonist, for example, tenofovir, actifibutide, and epcizumab. Okay, and then dipyridamole, which inhibits the adenosine uptake into the erythrocytes, but can also inhibit the platelets. Okay, so we look at the aspirin mechanism of action. Right, these are the important receptors. Okay, that is used, okay, by measure of our antiplatelets agent. Okay, so imagine this is our platelets. Okay, kalau dia tak aktif, okay, platelets ni in the resting condition, the shape is almost round. Okay, dia macam tu lah. Kalau dia aktif, dia akan, you nampak dia macam ada granules tu, dia dense, dia nak release the granules tu dah tak cantik, dan juga they have a fingers like projection. Okay, now you have COX-1 as a housekeeping cyclooxygenase in the platelets. Okay, and then we have a collagen receptors. Okay, collagen receptors is GP4. Sebab apa? When you have an endothelial injury, at the site of injury, I mentioned just now that you have an exposure of collagen. So bila dia roll dalam blood tu, bila dia roll kan, and then dia tiba-tiba dia punya reseptor tu can send, there's a collagen. Dia boleh interact. Okay, GP4 interact dengan collagen. Okay, so we call collagen receptors. And then we also have a thrombin receptors. Okay, thrombin receptors, receptors, and then we have we have a thromboxane receptors, which is the TP receptors. Okay, and then GP2B3A receptors that can interact with the fibrinogen and also von Willebrand factors. Okay, so the GP2B3A serves as the ultimate downstream signaling if you have platelets activation. It's meaning that is a strong activation. The downstream yang paling, let's say, kalau you ada this one activation, okay, COX lah, collagen lah, thrombin ke apa, at the end of the day, dia akan go to GP2B3A activation. Okay, and then it's a very strong activation pathway for the platelets, and let alone if you have von Willebrand factors exposure. So GP2B3A will interact with the von Willebrand factors. Okay, and then this P2Y1, P2Y12 is part of the ADP receptors. Okay, so there are the dua arms kat sini, P2Y1 and P2Y12 receptors for ADP, sebab dalam platelet ni dia ada granules, right? Dalam granule dia tu ada banyak chemicals lah. One of it is the ADP. So bila dia activated, dia akan release ADP. Dan ADP tu akan produce and goes to your blood circulation, and the other platelets will pick up the ADP that is in your blood. Okay, because they have the P2Y1 and P2Y12 receptors. Okay, so we look at the mechanism of action of aspirin. Okay, so the aspirin will inhibit COX-1. Okay, so siapa yang perlu kita bagi aspirin ni? Okay, so aspirin mainly is used for prophylaxis and the prevention, okay, for the thrombosis. Okay, orang yang ada high risk lah, kita bagi low dose of aspirin. Okay, low dose aspirin means about 75 mg. Okay, it can goes up to 90 milligram. Okay, early aspirin administration to all patients without contraindication within the first 24 hours of hospital admission and is the preferred antibiotic agent in the treatment of all acute coronary syndromes. Okay, aspirin produce 25% reduction in risk of serious vascular events, MI, stroke, vascular death in at-risk patients. Okay, for example, patient with previous MI, acute MI, previous stroke, acute stroke. Okay, so there's a term called aspirin resistance. Okay, there was a debate saying that okay, we should stop. Dulu kita bagi aspirin low dose to patients yang at risk lah. Okay, and when I come back and then I ask a few of our medical tanya siapa masa tu Dr. Rahman for example tanya okay, do we give the aspirin low dose aspirin? They said oh kita tak lagi dah, kita dah stop because it doesn't seem effective for the patient who at risk patient to prevent another episodes of MI or thrombosis. And I said, do you monitor? No, they don't. Okay, so this is a problem. In Malaysia, we don't monitor the patients. Okay, so sama juga macam kalau antibiotic is clear cut. You give antibiotic, kalau it doesn't work, then you can change to a different types of antibiotic with a different mechanism of action, and it's also due to the bacterial resistance. But for this type of treatment, you need to monitor. If then the patient does not respond to aspirin, you cannot just stop and do nothing. You might want to monitor why it doesn't work. Is there any other abnormalities in the patient? Or you can also change to the other drugs lah. Okay, and of course aspirin is the cheapest. The newest anticoagulant drug usually mahal. Okay, in terms of cost. Now, there's an issue with the methods of testing aspirin resistant. Okay, testing the platelets function is challenging enough. Usually kita akan pakai, the big hospital akan pakai yang platelets aggregometry daripada zaman 70-an tu yang besar tu je. But actually there are also a few other platelet testing that you can monitor kan dengan patient, tapi of course the mahal dan you need a skillful staff to do it. Okay, but I think we need to monitor before we say that okay, this patient has aspirin resistant and stop giving the aspirin. Okay. We use aspirin to prevent the acute thrombotic occlusion during PCI and likely stent thrombosis following the PCI. Okay, now the second group is ADP receptor antagonist. Okay, tentang yang paling tepat ialah P2Y12 receptor antagonist. Okay, for example, we have a clopidogrel and ticlopidine. Okay, this means irreversible inhibition of ADP receptors. Okay, clopidogrel was shown to be more effective than aspirin in reducing MI, stroke, and vascular death in a broad spectrum of at-risk patients. Okay, so let's say kalau you ada 24 events, 24th events out of 1,000 with the aspirin, it can goes down to 19 events. Okay, when you start giving the clopidogrel. Clopidogrel and ticlopidine is a standard practice in patients undergoing replacement of coronary stent. At least as well tolerated as aspirin. Okay, adverse effects, nausea, dyspepsia, diarrhea, hemorrhage, and leukopenia. Clopidogrel is preferred over ticlopidine due to fewer side effects. Okay, because ticlopidine is associated with neutropenia. Okay, therefore it needs a frequent monitoring of complete blood count. So for the patients undergoing primary PCI, okay, we should start a high dose aspirin, okay, to prevent the thrombosis. So high dose means 325 milligram. Kalau dos biasa berapa? for the pain, berapa? Ada belajar? Tak ada. Kalau low dose is about 70, 90, kadang-kadang we go up to 125. Okay? Right? Tapi kalau high dose tu is 325 milligram that we give or administered to the patient undergoing the primary PCI. Okay, so on top of aspirin, we can combine with the clopidogrel or prasugrel, which is also an ADP receptor antagonist. Okay. Adverse effects: nausea, vomiting, and diarrhea in 2 to 5% of patients, so that is very tolerable. Okay. Like for clopidogrel, for example, you start with the loading dose. Loading dose usually is higher, kan? Okay, then can reduce it to 75 milligram once daily as a maintenance dose. Okay. Right, so you can actually combine with the warfarin. Okay, but you have to monitor the INR lah. Okay. ADP receptor antagonist, we have a cangrelor and also ticagrelor. Okay, kalau partnership ni, we have a ticagrelor brand AstraZeneca known as Brilinta. Okay. Right. The third antiplatelet is the glycoprotein 2B3A receptors inhibitors. Okay. Mechanism of action, of course, it blocks the GP2B3A receptors. Okay, and therefore you will not have any platelets activation, no aggregation. Okay. And as I mentioned, this GP2B3A receptors is the final common pathway for platelets activation by fibrinogen and also for development factors. Okay, this drugs inhibits the cross-linking of platelets by the fibrinogen bridges between the GP2B and 3A receptors on the platelet surfaces. Okay, right. This drug is used to reduce the MI, stroke, and vascular death in patients with acute coronary syndromes. Okay, but it does not reduce the incidence of thrombotic events. Okay, parenteral administration in primary PCI where UFH is used, you can add glycoprotein 2B3A receptors inhibitors. Okay, in addition to P2Y12 antagonists and also aspirin. Okay, to reduce the likelihood of patients who have not received fibrinolytics. Okay, other drugs is tirofiban. Okay. Aduh, sakit mata tak? Okay. Yang suka tengok apa Barbie ke apa ke kan, mesti suka this diagram ni in pink. Okay, but it is a good diagram to show you, okay, where these drugs act. Okay, this is like a summary of the antiplatelets that you can refer to lah, I think. Okay, but you boleh tengok lah dekat sini, they have already mentioned the name of the drug, so let's say you can use this diagram to practice to remember the mechanism of action and the examples of the drugs under each category. Okay, or you can also refer to this one, this diagram. Okay, just to if you notice that the P2Y12 antagonists or ADP receptors antagonists, okay, they already classified it into 3 different groups, which is irreversible, reversible, and the third generation is also reversible. But I think for the third generation, we still not familiar with, I mean clinically. But for the first generation and second generation is a common antiplatelets or common P2Y12 antagonists that we use. Okay. Okay, so we have anticoagulant covered, we have antiplatelets covered. Okay, and then we have these 2 groups that acts on the fibrinolysis, or act as anti-fibrinolytic agents. Okay, so what is fibrinolysis? Okay, The coagulation system regulates fibrin clot formation, whereas the fibrinolytic system dissolves the polymerized clot and restores blood flow. Okay, so kalau let's say you dah ada, you tengok kalau let's say this is the clotting, okay, the clot initiation, and then you have a clot formation, and at the end you have a fibrin polymers that stabilize the clot. Okay, now we have this process called fibrinolysis to dissolve the clot so that the blood flow can pass through. Okay, right? So fibrinolysis is the physiological mechanism that dissolve or remove the clots, keeps the vessels patterned, and starts remolding the damaged tissue, which prevents the unnecessary fibrin clots and localized repair of damaged endothelium. Okay. The key reaction is the activation of the coenzyme plasminogen to the serine protease plasmin. Okay, the most important physiological activator of the plasminogen is the tissue type plasminogen activator TPA, which has a specific affinity to fibrin. Okay, TPA is expressed in the endothelial cells of the vessel walls, and it is released after injury and binds to the fibrin. When bound to fibrin, it is almost fully active. Okay, the co-localization of plasminogen and TPA further facilitates fibrinolysis at the sites of the fibrin clot. So again, this fibrinolysis is a localized process. Okay, kalau tak nanti it will happen. It will occur to your whole body, your system, your organs. Okay, so macam mana pula? Okay, so and apart from the TPA, we also have a UPA, urokinase. Okay, which is synthesized by or produced by the kidney and present in a high concentration in the urine. Okay. Okay, so this is the important part lah for the fibrinolysis, okay, where you need to have a plasminogen that is then and then convert to the plasmin, and this plasmin will recognize the fibrin, okay, and degrades the fibrin clot or the mesh of the fibrin polymer to be soluble fibrin degradation products. Okay, so who can activate this pathway? Okay, we have a plasminogen activator. Okay, I give you two examples, TPA and also UPA. Okay, so when you have plasminogen activator, it will activate the conversion of plasminogen to plasmin. Then the produced plasmin will dissolve the fibrin mesh. Okay. The other plasminogen activator is a streptokinase, which is a protein synthesized by streptococci. Okay. Mechanism of action combined with the pro-activator of plasminogen and form a complex that catalyzes the conversion of inactive plasminogen to active plasmin. Okay. So example of tissue plasminogen activator TPA that we use is alteplase, okay, and we have other retroplase and tenecteplase, okay. Okay. So that is to promote the fibrinolysis. Okay, maknanya we want to dissolve the clot. Now there are also conditions where the clot must not be dissolved. Correct? As, for example, when you want to prevent the bleeding, okay, so you kena bagi anti-fibrinolytic agent. Okay, so when we talk about the inhibition of fibrinolysis, okay, there are two target. Okay, we should target the here, which is the plasminogen activators inhibitors. Okay, this is where these PAIs work. Okay, and then we also have a plasmin inhibitors. Maknanya there are two steps lah. We target the plasminogen activator so that there is no plasminogen can convert to plasmin, and you can have the plasmin inhibitors that degrade or inactivates the plasmin that has been produced. Okay, right. So you have for this again for this plasminogen activators, you have septokinase and urokinase, and then TPA that's binds to the plasminogen. Okay, right. Then this PAI1, okay, plasminogen activator inhibitors 1 is an example of the PAI. Okay, and then alpha 2 antiplasmin is plasmin inhibitors. Okay, the plasminogen activator inhibitors are PAI1, which is synthesized in endothelial cells, adipocytes, and in the liver. Okay, if you have a deficiency of PAI1, okay, what happened? Okay, you cannot control the fibrolysis can happen, but anti-fibrinolytic will not happen. Okay, the physiological important inhibitor of plasmin is the liver synthesized antiplasmin. Antiplasmin binds to plasmin, but when plasmin is absorbed to fibrin, this binding is low, thereby keeping the fibrinolytic process ongoing and localized. If massive fibrinolysis is taking place, free plasmin will be available in circulation, and it will immediately be inactivated by antiplasmin to prevent systemic fibrinolysis. Okay, a bit panjang lah, baca balik. Okay, example of antifibrinolytic drugs. Okay, we have a TAEACA. Okay, apa nama panjang dia? Okay, clinical use. Okay, menorrhagia, dental extraction, and major surgery in patients with bleeding disorders. Okay, this is to prevent more bleeding to occur. Okay, biasanya kalau perempuan lah, in women when you have a menorrhagia, okay, usually you akan dapat apa? Tranexamic acid. Okay, to prevent more bleeding. So kadang-kadang dia kerap the bleeding tu kerap, the period tu kerap, and also prolong. Okay, kalau terlalu lama sangat can cause anemia and fatigue lah. Okay, contraindication, the dose has to be reduced in patients with renal impairment. EACA and TA are contraindicated in patients with renal bleeding. Okay, and this can be given as injection, or there are also oral preparation for the EACA or TA. Okay, this is how it works. Okay, for example, tranexamic acid, it binds to this plasminogen. Okay. Right. TA, tranexamic acid, is a synthetic amino acid. Okay, this one you can break up. Okay, after the first hour, 30% of the given dosage is excreted in the urine, and after 24 hours, 90% is excreted. Maximum plasma concentration is detected within 3 hours. Okay, half-life 80 minutes. This drug accumulates in the tissue. It passes through the placenta to the fetus and is present in breast milk, but the concentration is much lower than in the serum. No reported toxicity or teratogenic effects. Adverse effects: nausea, vomiting, diarrhea, abdominal pain, dizziness, and hypertension. Okay. Okay, EA is aminocaproic acid, EACA, okay, or epsilon aminocaproic acid. Mechanism of action: it binds reversibly to the domain of plasminogen and blocks the binding of plasminogen to fibrin and its activation to plasmin. Okay, these are the pharmacokinetics. Okay, please read. Okay, generally it's well tolerated for the adverse effects. Okay, but some GIT side effects has been reported, okay, and as well as dizziness and hypertension. Okay, so I just want to show you this. Okay, I think you have been familiar about this. The snake venom has this anticoagulant and procoagulant properties, right? Okay, so these are the snakes yang they have the venom that can affect the coagulation. Okay, the ular tedung raja, Naja is di Malaysia ada kan? the black neck spitting cobra. Ni apa? Ular tedung apa? Kita ular tedung ular tedung, ular kapak memang adalah content mouth ni di apa, di Australia yang di padang pasir tu dia banyak lah. Okay, but now the research, because we are in desperate to find a new anticoagulant, especially sebab because heparin ni ada banyak lah issue, we have to monitor the feeding tendencies banyak lah, and then kalau kita as a Muslim, we need to find yang halal lah, yang that is not porcine derived drugs kan. Okay, so this is one area of research that is currently is hot lah, in thing lah for the anticoagulants. Okay, and because in the snake venom too, there's a procoagulant and anticoagulant properties apart from the neurotoxin, hemotoxin, cardiotoxin, and cause necrosis. I'm not sure you will gonna discuss this in parasitology kan ya, the topic ni kan, topic ular, snakes kan. Okay, so it's a very interesting to learn lah about the property of snake venom. Okay, now as a conclusion lah. Okay, so when we talk about the treatment, okay, for the coagulation or anticoagulation ni, you have to make sure that regardless of the types of drug groups of category, you bagi anticoagulant ke or you bagi antiplatelets, okay, or fibrinolytic agents ke, there is always, put in mind that there is always a bleeding risk in patients. Okay, and then you have to make sure that it is valid in terms of efficacy to control the clot or the hemostatic plaques from to occur in this patient, but you need to have a safe or acceptable bleeding risk. Okay, kalau kena monitor tu, the activity dia, PT dia, you have to do it. Okay, INR. So kena ingat lah. Okay, and there are also many types of tools that we can use. Okay, these are the examples of the tests. Now, in hospital, they always monitor the platelet aggregation listener functions, but there are actually other tests that you can do. Okay, bleeding time, usually it's out lah, we don't use this anymore. Okay, and we are also we have a PFA, platelet function analyzer, and the other types of machine. I think now they have discontinued it because it's very expensive, but I have worked with the PFA. I think the closest country that had PFA was there's one in Singapore and another one in the Mahidol Hospital in Bangkok. Other than that, memang tak ada. When I come back to, I think if we have a hematologist from Ampang who asked me exactly, is it worth to have a PFA? And I said, why not? I have it in my workplace before, but it's very expensive. It's millions. Tapi senanglah untuk you monitor whether your patient tu is responsive to all this type of treatment. Okay, but we don't have that. But again, to reduce or to make sure that your patient tu has a safe or acceptable bleeding risk, you need to put this in mind that kalau if you have the opportunity to have more tests for your patient, please do so. Okay, so I think that's all for today. Thank you very much.